Good morning, everyone. My study is comparison of autorefraction to cycloplegic retinoscopy for prescribing glasses among school-going children. Introduction: refractive errors are one of the most common causes of avoidable and treatable blindness worldwide, and in younger children, if uncorrected, can lead to amblyopia. Accurate assessment of refractive error is crucial for the visual health of school-aged children as it significantly impacts their learning and overall quality of life. Two commonly used methods for evaluating refractive errors in pediatric populations are autorefraction and cycloplegic retinoscopy. Each of these techniques offers distinct advantages and limitations, and their comparative efficacy in a school-aged demographic is a subject of considerable interest. My objective is to compare autorefraction to cycloplegic retinoscopy in school-going children with refractive errors. Methodology: it is a hospital-based cross-section study done at duration of 1.5 years. Study setting in ophthalmology OPD at Government TD Medical College, Alappuzha. A sampling method, non-probability sampling, and my sample size was 180 eyes. Study population: patients attending the ophthalmology OPD. Inclusion criteria: the patient with symptoms suggestive of refractive errors among school-going children 6 to 17 years of old. Exclusion criteria: diminished vision due to causes other than refractive errors and history of any ocular surgery or retinal disease. Study variables include visual acuity, subjective refraction, slit lamp examination, dilated fundus, dilated autorefraction, cycloplegic retinoscopy followed by PMG. Results and discussion. The mean age group of the study population was 12.29 with a standard deviation of plus or minus 2.74. Out of 90 patients, 10 patients are in the age group of 6 to 9 years, 49 patients in the age group of 10 to 14, and 31 patients are in the age group of 14 to 17 years. Mean age group was 12.29 plus or minus 2.74. In my study population, 53.3% are females and 46.7% are males. In my study population, 84% was with myopia or myopic astigmatism, 10% was with astigmatism only, and 6% was with hypermetropia or hypermetropic astigmatism. And 76% had no significant difference between dilated AR sphere and cycloplegic retinoscopy sphere values. 7.7% had clinically significant difference of more than 0.5 diopter. And 93% have no significant difference between dilated AR cylinder and cycloplegic retinoscopy cylinder values. Only 5% have clinically significant difference of more than 0.5 diopter between dilated AR cylinder and cycloplegic retinoscopy cylinder values. And come to the conclusion: refractive errors are the most common cause of defective vision in children, significantly impacting their academic performance, social interactions, and overall quality of life. Early detection and timely correction through eyeglasses, contact lenses, or refractive surgery are crucial in preventing long-term visual impairment. Most common refractive error in school-going children, according to my studies, myopia or myopic astigmatism, which is increasing after COVID because of increased screen time in children. In conclusion, myopia is the most common refractive error, with its prevalence increasing globally due to genetic and environmental factors such as prolonged near-work activities and reduced outdoor exposure. And autorefractometer values and retinoscopy values under cycloplegia are comparable when performed under ideal conditions, particularly in older children. Cycloplegia minimizes the accommodation, leading to more accurate and reliable measurements. In older children who have more stable fixation and better cooperation, the differences between these two methods are minimal, making autorefractometry a useful and efficient alternative to retinoscopy for refractive assessment. The limitations of my study are only 10 patients were in the age group of 6 to 9 years, which constitutes a small sample size for this age group. As a result, the findings of this study are primarily applicable to older children aged 10 years and above, included only patients with refractive errors and excluded those with other causes of defective vision. Reduction in visual acuity observed in the participants was presumed to be primarily due to refractive errors rather than other ocular conditions. These are my references. Thank you.
5%, is it over predicting, over exaggerating on 0.5% or reducing 0.5% from the final values? You are saying no, 0.5 diopter, sorry, 0.5 diopters, that 0.5 diopters in a myopic person, was it over correcting or under correcting, you should say? You cannot just say it's variable by 0.5 because both has different connotation. Second is the three cohorts you used, that 6 to 9, 12 years, 12 to 15 years, they need different cycloplegics, no? Is it one cycloplegic?
No.
All three groups needed different cycloplegic. So that standardization is not there. What cycloplegia was used and how much that created value we aren't sure. So these two things you should standardize and try to do it in a bigger population. Okay. Even hyperopia you can leave off. Just take myopia because hyperopia needs more cycloplegia. So leave off hyperopia. Just take myopia. And in myopia, say whether it is overcorrecting or undercorrecting.
In your conclusion, you made two contradictory statements. One was that the results were comparable between the two things, and then again you were saying that cycloplegic group, the results were more accurate because it relaxes the accommodation. So that these are two contradictory statements.